Hi, everybody. Welcome back to another Therapy at Office Hour. My name is Zach Smith, and I'm going to be giving you a presentation on motor speech disorders and what you need to know on that topic to pass your praxis. I am a speech language pathologist. I am more medically trained and practice more in the medical realm of the field. Most of my career has been spent in acute care, but I've worked throughout the medical continuity of care. People with motor speech disorders have a really near and dear place in my heart. I love working with individuals who have motor speech disorders, and I'm really happy and privileged to be able to provide this presentation to you tonight. With that, I'm going to be sharing my screen and we'll get started with the presentation. All right, perfect. So what are motor speech disorders? Motor speech disorders, or I might refer to them as MSDs throughout the duration of the presentation, but they're any neurologically based condition that interrupts a person's ability to execute or plan the appropriate motor movements needed for speech production. We'll get into it in a little bit, but there's a whole process that starts with your planning of where exactly you want your articulators to go to moving that plan from your brain down to the muscles involved. So any breakdown in that process for speech specifically is what constitutes a motor speech disorder. There are two overarching categories of motor speech disorders, and that includes dysarthrias and apraxias. Dysarthria is more of a disorder of execution, so actually getting your articulators to where you want them to go, whether it's to place the tip of your tongue to the alveolar ridge, or the back of the tongue up towards your velum, for instance. Excuse me. And then apraxia is more of the disorder of planning and programming, or where we're talking about your brain has to formulate the plan of where all those specific muscles go and what sequence, et cetera. Apraxia is an issue getting that plan down. Either of these motor speech disorders can lead to impairments across a variety of different subsystems within the system of speech production, and that includes your phonatory system, your resonatory system, respiratory system, articulatory system, or dealing with prosody or extra speech characteristics. Um, Motor speech disorders can be caused by a wide array of different issues, which we'll get into it a little bit, but they are all related in some way to neurological damage or compromise. And most of the speech errors that we'll be going over tonight consist of what I like to refer to as SOTA, which is a nice acronym that you can use to remember that, and that stands for substitutions, omissions, deletions, or additions, SODA, which is why we've got that can of Coke there. We're not going to waste any time tonight. It's a lot of information to get through in a relatively short amount of time. So we're just going to jump right into dysarthrias. Like I said before, dysarthria itself is a motor speech disorder of execution. We already talked about what that means, but essentially getting your articulators to where they need to go to produce sound or word, etc. That encompasses what is execution. Dysarthrias themselves are defined by where in the nervous system the lesion occurs, the neuromuscular condition that results from that particular lesion, and then a wide variety of perceptual features, which we're going to dive into in pretty great depth here in a little bit. Dysarthria can exist independently. You'll see in a minute there are quite a few different types of dysarthria. You can have one, you can have two, you can have more than that. You can have a dysarthria co-occurring with an apraxia, and you can also have a dysarthria co-occurring with an aphasia. So sometimes it can kind of a little bit difficult kind of parsing things out as far as what issue you're seeing is correlating with which of the disorders that a person might have. But having a good foundation of this can help you through that process. All right. With that, we're going to jump into the different types of dysarthria, starting with flaccid dysarthria first. Flaccid dysarthria is a type of dysarthria that's caused by a lesion to any of your lower motor neurons. And by a lower motor neuron, I mean essentially anything from where your cranial nerves branch out to where the muscle, where they innervate the muscle themselves. So that's why I have in that picture there on the screen, it's highlighting some of the more lower motor neurons as they're exiting the brainstem, in the midbrain, excuse me. The neuromuscular condition that results from having a flaccid dysarthria is weakness or flaccidity, which is where it gets its name. You might see things like facial droops, weakness of one side of the tongue, that sort of thing. That's flaccidity. The perceptual characteristics that are associated with a flaccid dysarthria, if we break them down from those speech subsystems that I was talking about before, we have in the phonatory system, you might have a person who experiences breathy versus hoarse vocal quality. The reason for that is the vocal cords themselves can be weak, and it depends on where in their opening and closing phase they are, and if they have a difficulty moving them. So, for instance, if the person's vocal folds are more fixed towards an open position and they're so weak they can't really get them closed or they can't close them fully, they might present with more of a breathy vocal quality versus someone who, their vocal cords are closed, but they might be closed a little bit too tightly and they can't really get them open because they're weak. They might have a bit more of a hoarse vocal quality. Within the resonatory system, we can have hypernasality or nasal emission. That results from the velum itself not being able to fully lift up and close off the nasal passages as we're speaking. So they get excess sound output through the nasal passages, which results in hypernasality, or they might just have extra air coming through, which results in nasal emission. I can't really give you a good example myself, but if you think of someone who's speaking and they have a lot of air coming out of their nose while they're speaking, that's what nasal emission sounds like. Within the respiratory system, they may have audible inspiration. So again, if their vocal cords are a little bit too close to midline from when they're, taking a breath in or they're inspiring, you might hear them like that. That's an audible inspiration. And then if they can't modulate their airflow well enough, they may have short phrase length. So they might have to take a few breaths as they're speaking, which results in what I just did as an example of a 2 to 3 word phrase length, where normally we can speak a lot more and have quite a bit more words in our phrase length. Within the articulatory system, people with flaccid dysarthria may have imprecise consonant production. So again, if they have weakness in their tongue, their lips, their velum, etc., they may not be able to produce the sounds the way that they're supposed to, which can be perceived as them being imprecise in their speech. And then as far as their prosody goes, like I said, that's kind of extra speech characteristics. For example, our pitch elevating at the end of a sentence. To indicate a question, or lowering to indicate a statement, excuse me. Those are all prosodic features, word stress, sentence stress, things like that. So with that in mind, someone with flaccid dysarthria may be more monopitch because they can't really modulate their pitch to show the differences in some of the words and sentences they want to emphasize. They may also be mono loud. They may not be able to really get any louder than they are. So everything's going to come across as one level of loudness. As far as common causes go, this is by no means an exhaustive list, but some of the more common conditions that result in flaccid dysarthria include strokes, tumors along those nerves, any sort of trauma, and myasthenia gravis. As far as cranial nerves go, since we are talking about that, I just wanted to kind of go over a little bit of information for you guys on that with this presentation, because cranial nerves are very important to consider when you're looking at motor speech disorders. The ones that are involved in your speech production system include your 5th, 7th, 10th, 11th, and 12th nerves. In order, those are the trigeminal, which controls your jaw movements, your facial nerve, which controls lip movements and facial expressions, which is very important in our extra speech conversation, but also in some other languages. So like American Sign Language is heavily based on facial expression. Your vagus nerve is important in voice and voicing production. Your spinal accessory or 11th nerve is important in neck and shoulder control. And we're going to get into that more so a little bit later in the presentation, but something to keep in mind. And then your 12th or hypoglossal nerve controls your tongue movements. So you can see if you have damage to any of those, how much your speech system can be impacted. If this video, I should. I'm going to try and play this for you just as a speech sample for someone who has flaccid dysarthria so you can hear what it sounds like.
But the king and queen are not happy. There were no little children in the house or garden.
All right. So brief 8-second clip, but you can see there was, slurring of speech, imprecise consonants, mono pitch, mono loudness. There was a lot going on in that clip there. But you could tell just from when he was speaking, he sounded weak, like he couldn't move his muscles, as efficiently as he may have been before whatever caused his flaccid dysarthria. So that is an example of what a flaccid dysarthria might sound like.
But the king and queen were not happy.
Sorry. There we go. Okay, so next on our list, we have spastic dysarthria. Spastic dysarthria is a type of dysarthria that's caused by bilateral lesions to your upper motor neuron. So now we're talking about your cortex, which is why I have both sides of the brain on the picture there highlighted. And this is an important characteristic as far as helping you diagnose what type of dysarthria is present, which we'll talk about more on in a little bit. But if you have bilateral lesions, the resulting neuromuscular condition is spasticity. You can think about that as kind of tightness or excess, stress and tension in the muscles. The perceptual characteristics that result from that. Again, you can have breathy versus hoarse vocal quality. So with this one, it's not that the vocal folds may be so weak they can't do it. It's that they may be so tight in whatever position they're in. So they may be tightly out to the point where the person can't get them in and they are breathy. Again, it could be, they're slammed so tightly closed and they're, really, really tight, then you're going to get a hoarse vocal quality. People with spastic dysarthria can have low pitch. They can have pitch breaks where their pitch just kind of falls out. Then they might also have a strained, strangled vocal quality, and that's something that's used to describe. It's kind of a sound of, the example is if someone's literally trying to strangle you by grabbing your neck, and you're trying to talk on top of that. I'm just really trying to press your voice out, kind of like that. It's not the best example, but it's the best I can do. But again, think if you have someone whose vocal folds are pressing so closely together like that, it can result in a strained, strangled vocal quality. With the resonatory system, they may experience hypernasality. Again, it's because the velum's not able to get up enough to block off the nasal passage, but this time it's probably because there's too much tension in those muscles. You can't really get that person to move it up. In the respiratory system, again, they might have short phrase length. In the articulatory system, they might have imprecise consonants. They might have distorted vowels if their muscles are so tight that they can't really move the articulators to where they go. That can even impact their vowels, where, if you need to have a high front vowel and their tongue is so spastic that they can't get that up, the vowel might come out as something different. And then as far as their prosodic system goes, people with spastic dysarthria tend to be monopitch, monoloud. They can have equal and excess stress, throughout their productions. They can have reduced stress, and then they may have a slow rate of speech. The common causes of spastic dysarthria are things that are going to cause damage, again, bilaterally in the cortex. This doesn't have to necessarily be one inciting instance, but it can and typically is. You're looking at things like a traumatic brain injury where you might have, a coup injury on one side versus a contra coup on the other. So you have bilateral damage there. If the person has multiple strokes throughout different, the different hemispheres, that can do that. Or, progressive neurological disease, something like an, ALS, where it affects, in that case, their whole brain, but it does affect both cerebral hemispheres. That's going to result in a spastic dysarthria. All right, we're going to listen to another clip. In this clip, the younger person on the right side of the screen with the white shirt, he is the person with spastic dysarthria. So I want you to listen to him speaking, and then we'll kind of just review quickly what his speech characteristics are.
I'm going to show you this picture. Can you tell me what's happening in that picture?
It's a ball sliding.
Okay. Can you make up a story about it?
It's a ball and not slide.
Okay.
All right. So with that, your ears may not be as trained as far as the difference in vocal qualities. You will get there though, but with this one, he had a little bit of breathy vocal quality. He had a little bit of strain and strangle. He had shorter phrase lengths. He would had that slow rate of speech. So kind of, using those perceptual characteristics to match up to where the lesions are, those sorts of things that can really help you narrow in your diagnosis. All right. Next, we have hypokinetic dysarthria. This is a type of dysarthria that's, excuse me, it's caused by a lesion in the basal ganglia, specifically in the substantia nigra, where if we're looking in this image here on the right side of your screen, with the substantia nigra, the label is down here, we're going to follow that up, and it's right in this area here. So this whole portion here is the basal ganglia, but lesions there are associated more so with hypokinetic dysarthria. The resulting neuromuscular condition is rigidity. It's somewhat similar in spasticity, where muscles are, you can perceive it as tightness, but with rigidity, the big one is someone with Parkinson's disease, which I have in the slide down there. They might have something called cogwheel rigidity, where I'll turn and hopefully you can still see me in the top portion of the screen, but you might ask them, to lower their arm like this instead of one fluid motion. They might have something that looks kind of like, if you're pushing their arm, it might be like that, because their muscle is rigid and doesn't really want to move. They can move it, but it's more rigid in the movement like that. So keeping that separate from spasticity, you might think that they're similar, but they are different. With hypokinetic dysarthria, the perceptual characteristics include a breathy versus a harsh vocal quality and low pitch. They don't really have any changes notably to their resonatory or respiratory system. They can, but that's more in severe cases, not kind of common across whatever variety you're looking at. In the articulatory system, they can have imprecise consonant production, repeated phonemes, similar to stuttering, and they can have short rushes of speech. And what that means is they might be speaking, and then while they're speaking, part of their sentence starts to really, really speed up to the point where you may not be able to understand that. I can't give you a good example of that myself, unless I speak really slowly and then I start to speed up at the end, I'm going to talk like that. That's what a short rush of speech is. And as far as prosodic features, this is where you might see more changes in a hypokinetic dysarthria case, where the person might be monopitch, monoloudness. They may have reduced stress. They can have an increased or a variable rate of speech, again, with those short rushes of speech. You might start quote unquote normal, and then you're really fast toward the end. So you can have that variable rate of speech, and then they can have inappropriate silences where they might just be not speaking, or they might have the difficulty kind of getting things going to speak to you. The most common cause of this is Parkinson's disease, as I alluded to earlier, but you can have strokes in the basal ganglia that impact the substantia nigra and can result in hypokinetic dysarthria as well. All right. If you've taken your motor speech disorders class already, you may have seen this video. It's a very popular video as far as example of what hypokinetic dysarthria sounds like. The woman that's smiling there in the pictures, who we're going to be listening to. I'm not going to play this whole video, but if you're interested, you can just search LSVT loud speech therapy for Parkinson's disease and find her. She's like the top video for even hypokinetic dysarthria. But this video shows what she sounds like pre and post treatment. We're just going to be listening more for the pre-treatment to see what she sounds like.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Anything else?
I stutter, which I never did before.
Okay. So in that clip, you could hear she was mono loud. She had mono pitch. She had reduced loudness. She wasn't so imprecise with her consonants, and we didn't hear it, but she did allude to that repeated phonemes that people with hypokinetic dysarthria can experience. And then one thing that she doesn't have terribly, but it's something to keep in mind also for people with hypokinetic dysarthria, is that they can have something called masked faces, and with that, it just kind of looks like they don't really have any emotion on their face. They're very straight faced. They have a hard time, showing emotion. That's part of, the issue, not anything that they're causing on their own end. And I bring that up because if you do watch this clip toward the end, you'll see towards the end after she's gone through her treatment and she's got better control of all of her systems. She's a lot more exuberant and smiling. And I'd like to say that's just because she loved her speech therapy so much, but it's actually an impact of the hypokinetic dysarthria and the lesion that she has in that area of her brain. But when she goes through treatment, it obviously improves for when you watch the clip. So just something to keep in mind as far as the distinguishing characteristic of this issue as well. All right. So we just spoke about hypokinetic. Now we're going to go on the other hand and speak about hyperkinetic. If we think about hypo meaning, less movement, you can think of hyper meaning more movement. It is also caused by lesions in the basal ganglia, this time specifically in the caudate and the putamen. Again, if we look at the picture up here, your caudate nucleus is right over here, kind of over the superior aspects of your basal ganglia, and then your putamen's right down here. So more centrally located. Those two areas are more highly associated with a hyperkinetic dysarthria. The resulting neuromuscular condition is involuntary movements. You have a lot of different conditions. I'm not going to go over all of those with you right now, but you can have tics, tremors, something called athetosis. You can have something called bulismus. They're all just different types of movement patterns. These are really highly occurring with these hyperkinetic dysarthrias. And that's not necessarily speech production, but you might have someone who has these involuntary movements, and when they're speaking, they might start to lift their arm up like that, or go back like that. Things along those nature. They're associated with the conditions that result in a hyperkinetic dysarthria. They can have involuntary movements in their speech, which we're going to get into in a second. But just to be aware that it does impact more than just their speech production. Perceptually, people with hyperkinetic dysarthria have harsh vocal quality, strained, strangled vocal quality, transient breathiness, and voice stoppages. Those last two, I want you to think about that involuntary movements, and that's an involuntary movement of the vocal folds themselves. So they could be talking, and then all of a sudden their vocal folds involuntarily slam open, and then they have transient breathiness, but they also have their voice stoppage too, where they just can't get a voice out. Respiratory system wise, they tend to have hypernasality. In the respiratory system, they have excess loudness variations. Again, they can't modulate anything because of that involuntary movement, so their loudness is all over the place. They have shorter phrase length, sudden forced inhalations where they're talking, and then they have to go like that. Excuse me, that hurt my throat. But that's again an involuntary movement that they can't control. From the articulatory system, they again have imprecise consonant production, distorted vowels, irregular articulatory breakdowns, and prolonged phonemes, where they're actually prolonging the phoneme that they want to try to produce. And then in the prosodic system, they have monopitch, monoloudness, reduced stress, a very low rate of speech, inappropriate silences, prolonged intervals, and then excess and equal stress. The most common cause of this type of issue is Huntington's disease. And we're going to watch a case here on the next slide. I just got to skip ahead here.
Our team put together this presentation to really tell.
Pride for himself. He only ever thought about his daughters.
I recall first seeing Megan would possibly become symptomatic, that it wouldn't be an issue for him.
There we go.
Hi, everyone. I give a big today.
Right. So even with that short clip there, we saw inappropriate silences, prolonged intervals. She had imprecise consonant production. She had that, forced exhalation there in the middle of her sentence. And then and when I play it a little bit more, you can see she does have a little bit of those involuntary movements outside of her speech system here in a second.
I am 20. When I was a sophomore at fifth year college in Nashua, I found out I had a juvenile Lyme's disease.
There we go. So that kind of lurched back. That was that involuntary movement that I was talking about. That's associated with hyperkinetic dysarthria. All right, moving along. The next one we're going to talk about is ataxic dysarthria. Ataxic dysarthria is a type of dysarthria that's caused by a lesion in the cerebellum. Your cerebellum is this kind of second smaller brain at the back here that's really involved in the coordination of your movements to make sure things are coordinated and smooth. So with that in mind, your resulting neuromuscular condition is discoordination. If you have a lesion in the area that helps with coordination, you'll be discoordinated. Perceptually, these people have harsh vocal quality and voice tremor. They have a hard time coordinating their vocal fold movements, and that results in a voice tremor. In the respiratory system, they typically don't have any impairments. In the respiratory system, they tend to have excess loudness variations. Again, they can't coordinate all of the pieces that are involved in keeping consistent loudness, so they might be really quiet and then they might get really loud within the same phrase, just like I did there. In the articulatory system, they might have imprecise consonants, distorted vowels, irregular articulatory breakdowns, prolonged phonemes, and then a really, really important feature of ataxic dysarthria is something called telescoping of speech. I cannot give you an example on my own as far as what it sounds like, but you can think of telescoping as kind of bridging over or smushing an entire word, into one really quick blip. I really encourage you to look that up online and to listen to some audio clips so you can really hear what it looks like. But telescoping is so highly associated with ataxic dysarthria that even if there's a question of what it might be, if you hear that, you can help narrow in your diagnosis as far as that goes. And then in the prosody, the prosodic system, excuse me, people with ataxic dysarthria tend to have monopitch, monoloudness, prolonged intervals, and then equal and excess stress. Common causes of ataxic dysarthria include stroke, trauma to the cerebellum, and then any genetic condition that results in issues in the cerebellum itself. All right, we'll listen to a clip here.
My motor nerves, always seem to have been put there by him.
Mhm. And how long has this been going on?
For about a year, continuously.
And have they actually figured out what's wrong?
Not yet,
Not yet.
not for sure.
Okay. Let me have you do a few things for me.
Okay.
First, I want you to count from 1 to 20.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 15, 14, 15, 16, 17, 18, 19, 20.
All right. In that clip, that was actually an example of telescoping there where he kind of smushed 13 together. But he also has monopitch, monoloudness, irregular articulatory breakdowns as well, just to highlight a few perceptual features from this video.
My motor nerves.
There we go. All right, next up is unilateral upper motor neuron dysarthria, or UUMN. And this one is associated with unilateral upper motor neuron damage. So earlier we spoke about spastic dysarthria being caused by bilateral damage, and I said it's important to know the difference. And this is why. If you have damage on one side of your cortex, you may have a unilateral upper motor neuron dysarthria, excuse me. So that is a distinguishing characteristic as far as if you're looking at neuroimaging on your patient. The trouble with UUMN dysarthria is there are a lot of different things that you might see, just because this issue tends to not be as severe as some of the other dysarthrias that are out there, just because of how wiring in the brain works and innervation of our muscles. You may have some weakness versus discoordination versus spasticity. And again, I stress some because these are not typically as severe as a flaccid dysarthria, an ataxic dysarthria, or a spastic dysarthria. Someone with a UUMN dysarthria might have a harsh vocal quality or a hoarse vocal quality. They may have hypernasality with nasal emission. There can be decreased loudness, imprecise consonant production, irregular articulatory breakdowns, and a slow rate of speech. Common causes, again, anything that causes unilateral cerebral damage, excuse me. So stroke, trauma, tumors, etc. All right, and we're going to listen to this woman, Stacy, here, to see what she sounds like with her UUMN dysarthria.
April 2nd at 6:42, and the sensation is happening again. Just smile, they said, smile. It's all tingling on the left side, on the left side. The doctor said to breathe.
Okay, so with that one, you can see obviously she has the facial drooping, so she does have some weakness. She's got some imprecise consonants, things like that. But if you think about the video examples that we've gone through already tonight, we can understand very nearly 100% of what Stacy here is saying. Where if we think about comparing her condition as weakness, so if we compare her to the case of flaccid dysarthria that we listened to earlier, it's not quite as severe. And that's kind of the hallmark of a UUMN, is that it is obviously a dysarthria. She does have some changes in speech, but it's not as severe of a case as some of the other ones that we may come across. All right. Lastly, as far as dysarthria goes, we are going to talk about mixed dysarthrias here. This one is a bit of a mixed bag, no pun intended, because it really depends on where the lesions are and what types of dysarthria you have presenting. So lesion-wise, more than one location. And with that, I mean more than, like we're not going to count the bilateral cerebral hemispheres as more than one, but you're going to have both cerebral hemispheres and your cerebellum, or you could have, your basal ganglia and unilateral lower motor neurons on one side. So the neuromuscular condition is obviously going to depend on where in your nervous system the lesions are. The perceptual characteristics are going to vary based on what dysarthria is present. Typically, the issue is more of these degenerative widespread diseases like ALS that are going to cause mixed dysarthrias. But you can have someone who's had repeated strokes. I've worked with people in my career who've had, unfortunately 3, 4 more, different strokes in different areas throughout their brain, over the course of a span of like 10 years, and they've ultimately ended up with mixed dysarthrias. So that's another example of how this can arise. But since we were talking about ALS, this clip is someone who has ALS. It already gives it away in the title there, but this is going to be a case of mixed spastic flaccid dysarthria. And we're going to listen in on how she sounds. Okay,
My baby ate a mother's rain.
Okay, she's repeating, my baby ate a cupcake on the train. Say it one more time.
My baby ate a cupcake on the
Oh. Sorry for...
Okay. Can you say West Register Street?
There we go. Sorry about the tech issues on my end. But with that, we can go over the perceptual characteristics, but breaking things down into where is the flaccid and where is the spastic can be a bit challenging, since a lot of these perceptual characteristics, are shared amongst dysarthrias. She has imprecise consonants. She has hypernasality. She has nasal emission. If you think about those 3 on their own, they were in almost every one of the types of dysarthria that we spoke about. So really knowing, where your lesions are, what perceptual characteristics are associated with others, and neuromuscular conditions. So she's got the spasticity and weakness, things like that, that can help you parse things apart and help you land on your diagnosis as far as what type of dysarthria you might have. All right, with that, we've wrapped up dysarthrias, so we're going to move right along into apraxias. As I said earlier, apraxia is a motor speech disorder of planning and programming. In the acquired variants, it's usually associated with a lesion in the frontal parietal areas of the left hemisphere. Sorry, I have a typo there. I noticed that. It's a lesion in the frontal-parietal area of the left hemisphere, but not always necessary to cause that. It reflects a difficulty in smoothly transitioning between sequential movements for volitional speaking tasks. So we're not talking about producing just an individual phoneme. Some people may have that issue of transitioning from nothing to that phoneme, but it's more so the phonemes between or in a word. So, with word, it's what or d. They may have difficulty going from the what to the to the d. That's that, smooth sequential transition. There is a lack of a neuromuscular impairment with this condition. So we spent a lot of time recently talking about weakness versus spasticity versus discoordination. If it's just apraxia isolated on its own that's presenting, they do not have an associated neuromuscular condition. That being said, if you have an apraxia co-occurring with something like a dysarthria, the dysarthria can have that associated neuromuscular impairment. So you might have someone with apraxia who does have weakness or does have spasticity, but it's not caused by the apraxia itself. Apraxia has been something of a moving target in terms of definition, because you'll see it can be very challenging to diagnose. And we're going to get into that in a little bit. First, apraxia that we're going to go over is an acquired apraxia of speech. So I say acquired, that means it's not something that was caused by natural development. So you might have something like a cerebral palsy that results in a dysarthria. You can have prenatal damage, peri or postnatal damage. This would be after, in the postnatal period, something like a stroke or brain tumor, things like that, where it's acquired. It does cause that difficulty in programming and planning, the movements needed for motor speech production. And there are many unique, but also more universal too, characteristics used to diagnose. So speech, if we're looking at just speech characteristics, we've already talked a lot about consonantal distortions for dysarthrias, but vowel distortions are more associated with an apraxia. They may have lengthened speech segments, speech sound substitutions, and then another big two are articulatory groping behaviors. I have a video where I can show you what that looks like in a little bit. But essentially, outwardly, it looks like the person's really trying to think hard about where they want to, what they want to say. And they're really just groping for, trying to figure out where they need to put their articulators to get that sound out that they want. And they can also have initiation difficulties. Like I said, some people can have a challenge of transitioning from not speaking to the act of speaking, like I just did there. Sequencing wise, like we said, sequencing is a big hallmark of apraxia. They can have a slow rate of speech. They can have lengthened intersegmental durations. They also tend very highly associated with apraxia. They have an increase in the number of errors as their utterance length or the complexity of what they're saying increases. So the longer the utterance or the more complex the utterance, the more errors are likely to be there relative to, like short words or short phrases, for instance. That is a hallmark of apraxia. Someone with a dysarthria would probably have difficulty no matter what level you're working on. Whereas the errors are going to exponentially increase as your complexity goes up if you're working with someone who has an apraxia of speech. Other characteristics outside of that, they may have abnormalities in prosody. They may have better awareness of their speech difficulties. Their automatic speech is better. So if you think about something that is so highly ingrained in us as a society, let's say, for example, someone sneezes, you're going to say, bless you, or God bless you, or whatever variant you grew up with. That is something that is just so ingrained. People say it without even thinking. Someone with apraxia might say, might not be able to say anything, and someone sneezes and they can still say, God bless you. Reason for that is their automatic speech is better. Perceptual characteristics are associated. There are perceptual characteristics that are associated with acquired apraxia of speech. I broken them down into articulation, rate, and prosody, and then fluency. Because fluency or that smooth transitioning is important in apraxia specifically. In the articulatory area, we have errors often reflect simplification of target sounds. So they can make them a little bit easier or like a simpler variant of them. They do have a lot of consonantal distortions. There are perseverative substitutions, anticipatory substitutions. There are voice and voiceless boundary inaccuracies, where they just can't turn off their voicing or they can't turn it off. In between voiced and voiceless phonemes, and their errors are inconsistent. That is another very important perceptual feature of apraxia, excuse me. Someone with a dysarthria, their errors are usually very consistent. If you think back to like an articulation where you're looking at, place, manner, voicing, they might not be able to produce voiceless fricatives very well. They're going to work on that one, but someone with an apraxia, if you told them to say that 10 times, 5 of them could be perfect, 3 of them could be a little bit off, and then the other 2, they wouldn't be able to produce at all. They're so highly inconsistent. As far as rate and prosody goes, people with apraxia tend to have a slow rate of speech, particularly for multisyllabic productions. So the more complex, they tend to get a little slower, so they can try and get everything they need to say out. They can have prolonged vowel durations, syllable segregation, just like what I did there. Equal stress across syllables and words, so kind of that mono stress that we talked about. And then as a rate increases, their accuracy decreases. So as they're speaking more and more quickly, their accuracy tends to plummet. They may also come across as having a foreign language, or excuse me, a foreign accent to you. Whereas, they might be someone who had, what's called the standard American accent, no accent at all, and now they sound like they could be from another country. That is part of that apraxia. It's just the way that their speech sounds after that neurological issue has manifested. As far as fluency goes, people with apraxia tend to have attempts to self-correct pretty frequently. They might have false articulatory starts or restarts. So they're going to say something, they stop, and they're going to go again. Again, effortful groping. I'm not even going to try to show you personally what that looks like. I'll wait for the video. And then they can have temporary pauses of their articulations during speech. All right, here's that video I told you about. We'll listen here.
Hi. My name is.
All right, so in those 11 seconds, we had a prolonged phoneme in my name. She had a vowel distortion from is to ease, and what she's doing right there, where she looks like she's searching really hard, that is that groping. She's really trying to figure out where she wants to go next.
Hi.
There we go. Okay. I apologize for all the tech issues tonight. I do not know what is going on with my computer here. Okay, so we spoke about acquired apraxia. Now we're going to talk about childhood apraxia of speech. This is an MSD of childhood in which the precision and consistency of movements for speech production are impaired, again, in the absence of neuromuscular conditions. And this is going to become really important if you're working with kids and trying to determine whether they might have a childhood form of dysarthria or a childhood apraxia. Again, the core deficit remains in planning and programming, just as in the acquired variant. It is a relatively rare speech disorder. It's estimated that about 3 to 5% of pediatric speech disorders, are childhood apraxia of speech. The rest being those caused by childhood dysarthria, articulation disorders, phonological disorders. Childhood apraxia of speech is most often congenitally associated, but it can be acquired after birth. And then there is no accepted notion of a localized deficit in the brain. So how we talked about the acquired variant is usually more associated with those left frontoparietal issues. There's not a really good agreed upon lesion in the area or lesion in the brain that we accept in CAS. Again, this is another disorder that was pretty hard to define. So in 2007, ASHA got together and they came up with what they called their consensus features for the diagnosis of childhood apraxia of speech. With that, they said that inconsistent errors on consonants and vowels in repeated productions of syllables and words was one feature. So if you're having them produce syllable after syllable after syllable, and they're having inconsistent errors on both the consonants and vowels, or, same thing with words, that is a feature of CAS. They can have, lengthened and disrupted co-articulatory transitions between sounds and syllables. So again, we've talked about that smooth transition between sounds, smooth transitions between syllables. If they have lengthened or disrupted transitions, again, childhood apraxia of speech. And then they can have inappropriate prosody, especially in the realization of lexical and phrasal stress. We already kind of went over this a little bit in those perceptual characteristics that Asha put out, but we're going to go over it a little bit more detail. Again, kids with CAS have consonantal errors. Omissions tend to be more frequent than substitutions. So if you think of something like bat, they might say ba or at. Things like that, where just one of those sounds is completely omitted. And then they tend to have vowel errors. So they're distortions in their vowels and vowel reductions, meaning they took the vowel and they reduced it to more of a centralized schwa-like vowel. So instead of bat, they might say but. Sequencing characteristics include difficulty initiating or transitioning between articulatory gestures. That sounds like we were just talking about with acquired apraxia, where they may have difficulty going from not speaking to speaking with that initiating speech movement, or transitioning between sounds and words, syllables and words, words and phrases, words and sentences, etc. Other characteristics of CAS include coping behaviors. They have slower alternate motion rates, which we'll get into in a little bit. They have that syllable segregation again, schwa insertion. So it's as a bad example, I can't even think of a word. If we're looking at a word like baseball, that's a 2-syllable word where there's one syllable and then another. They might insert a schwa in the middle of it to make baseball. That's a horrible example, but it gets the point across. They can have voicing errors. So if a sound is supposed to be voiced, they might make it voiceless and then vice versa. And then they also, again, have difficulty with multisyllabic words. All right, we're going to listen to this little boy here speak, and he has CAS.
Hurry up, and then we're gonna do these. Mama, go ahead. And this one is the bite your tongue. Da da. Da da. Good. And the sheep says, lips together. You do it. Ba. Yes, do it 2 times. Ba. Okay, now do it again. Ba ba. Ma ba. Do it again. Ba ba. Ma ba. Not ma ba. Ba ba. Ba ba. You got it. So Nancy, ow. Ow. Now put on the good. So when you want to get out of here at the last part of the day, then we're going to work on out functionally. Out, like as in let me out. All right. What is that again?
All right. So with that one, you could see he had those that difficulty initiating when he was first told to say ba. She had to point and tell him, you say it, and it got him to go. He had changes from ma to ba. He also had difficulty and omission of that T at the end of out, and she had to point it out to him that he needed to add that on there. In a little bit in this video, they get into working on it, and he tends to really perseverate on out instead of making it more fluid. So he's kind of breaking up and segregating that word to make it easier for him to say. All right. That is apraxia in a nutshell. I know this is a lot of information I'm throwing at you. Motor speech disorders is a wide area of disorders in our field. But I want to be mindful of your time, and I want to really just give you kind of the nuts and bolts of what you need to pass your praxis. So we're moving on straight on to assessment of motor speech disorders. Just like any other issue in our field, the purpose of assessment in MSDs is to develop an idea of what areas this person has strengths and weaknesses so that you know what to target in therapy. Overarching portions of a motor speech disorder evaluation include a case history review. So you might look at medical records, in the case of an adult, or if you have a kid who has more of an acquired issue, like they had some sort of issue at birth and resulted in dysarthria, you're going to want to know that. You talk to the patient, talk to the parents in an interview to get a bit more information about them, what they're looking for, what they sound like, and then you're going to do your assessment of the different subsystems of speech as well, so you can really narrow in on what exactly is going on with these patients you'll see. depending on how your patients perform during the evaluation, that's where you can consider which speech subsystems to target in therapy, as well as what appropriate approaches you want to use for them. All right, we're going to break it down. There is going to be some overlap, but more, to kind of make it a little bit more clean as far as what goes where. I'm going to break things down in terms of subsystem. With the evaluation of the articulatory system, you're going to want to start with an oral motor examination. That allows you right off the bat to determine if you see any weakness, facial drooping, tongue deviation to the side, velar elevation on one side versus the other, spasticity, muscle tightness, etc. Right off the bat, you can do that. So, smile, pucker, stick out your tongue, lateralize the tongue to the sides, elevate it, lower it, puff out the cheeks, things like that. This can also help you narrow in on what cranial nerves might be impaired. So if they smile and only one side of their face goes up, it's cranial nerve 7 is impaired. If they can't really open their jaw too much, cranial nerve 5. If their voice, if you have them phonate for a volitional ah, and their voice sounds like ah, you can take a guess that it's cranial nerve 10, things like that. Sequential motion rates and alternate motion rates. So this is a way for us to really talk about, the fluency and of speech as far as repetitive speech movements go. So sequential motion rates and alternate motion rates are going to be also referred to as diodochokinetic rates. So with those, you might have someone say, ba, ta, and ka, ba, 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 ta, 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 ka, 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 or pa, 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 things like that. And then you want to put them together. So padika, padika, padika. If you're working with a kid, you might come across how to say caterpillar, caterpillar, or buttercup, buttercup. That's just to make it a little bit more friendly for the kid. Kids like to have more engaging therapy. So you might have to do stretches like that. But if you have someone who is saying, like that, or that gives you an idea of what their the fluency of these speech movements look like. You're going to have word production tasks to see what their articulation looks like on different types of words. Something really important to help you differentiate dysarthria from apraxia is you want to have words of increasing syllables that sound similar. So the example that I gave you there is cat, catnip, catapult, and catastrophe. You can see each of those as one syllable more than the one that precedes it, but they all start with cat. And why I say that, because they're very phonologically similar in the beginning of the word. So you can build up from there and see, are they going to say catnip, matapult, catastrophe? That's a bad example, but they at least got one and they're very variable. Or are they going to be fine with cat and catnip, and then they're going to get catnip, cat, pull, things like that. That can help you. Again, multisyllabic words and repetitions of these multisyllabic words. So caterpillar, 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 snowman, snowman, snowman. Again, multisyllabic tends to be harder for apraxia. So you can see if they're going to break down with these more multisyllabic words, and then repeating will also allow you to see, are they going to break down at the same frequency, or their R is going to be variable. You can also do phrase production tasks, sentence production tasks, and then ultimately you want to develop what's a rating of speech intelligibility. It is a subjective measure that essentially boils down to what percentage of their speech did you understand. So you might rate someone as being 50% intelligible, which means you understood half of what they said, or 75% intelligible, things like that. It's your rating of how that person sounds to you. All right. As far as the phonation and respiratory assessment, they are so highly intertwined that they are going to be evaluated together. You want to initially take note of your patient's posture because that can impact their voicing, their breathing, and it's something that you may want to intervene on in therapy. So for example, I'm going to turn to the side. I hope you can see me again. If you have a patient who comes in and their posture looks like that, head down, shoulders rolled, they might not have great neck and shoulder control, like we were talking about with cranial nerve 11 in the beginning of this lecture. But if they're stimulable to keep themselves up, or you think they might benefit from some other type of therapy, that's something you can work on. You want to time their maximum phonation time. So you're going to tell them to take a deep breath and say ah at a pitch and loudness that's comfortable for them, and time how long they can say that before they either stop or take a breath. The reason for that is that tells you how well they can coordinate their breathing and voicing systems. Normal tends to be as we're approaching around 20 seconds. There is some variety for gender, age, and body build. Also, someone who's like a professional singer, they're going to be able to do this forever. But that gives you some information, So if you have someone who says, that they're having some sort of difficulty with phonation or respiration. The S to Z ratio, it's similar to the maximum phonation time, but you're going to have them do S and Z for as long as they can. If they have a longer S versus a Z, that tells you that they might have problems with their voicing, where they just, they have an issue there. Or if their S is longer than their Z, it could be just difficulty modulating their airflow. Where runs out really quick because it's just all the air is coming out. You want to have them do pitch glides both up and down. So like that. That'll give you an idea of what their pitch flexibility looks like. Amplitude variations, it's the same thing as a pitch glide, just with amplitude instead of pitch. So I didn't change my pitch too much there, but I got from quiet to loud. You also might want to have them count on one breath. It gives you similar information to the maximum phonation time, but with more of a functional twist. So take a deep breath and count as long as you can. You also want to make note of their breathing patterns. So whether they're breathing from their chest, their abdomen, I can't show you because I'm out of screen, but does their belly go out when they breathe in? Or are they having paradoxical breathing? So that means doing the opposite of what's expected. So if they breathe in and their chest caves in versus if they breathe out and it goes out, that's a paradoxical breathing pattern. As far as resonation assessment goes, you're really just going to be listening for whether they're hyper. So do they have a lot of that nasal, energy and sound coming out, or are they hyponasal? Do they sound like they are stuffed up and have a cold? You really want it to be specifically in instances where it should not be. So if they are saying, like an M-loaded sentence, so like my mom sells lemon muffins, that's got a lot of M's. You're going to hear a lot of hypernasality. You don't want to make a judgment that someone's hypernasal off of something that should be a nasal sound. But if they've got, I'm trying to think of another sentence. Peter keeps at the peak. It's something from the Kate V and voice assessments, which I'm sure you'll go over in the voice disorders office hour. But that should not be hypernasal. If they have a ton of hypernasality in that type of a sentence, that would be pathological. That's what you're looking for. Something to test for nasal emission too could be what's called the cold mirror test, which I have pictured there. You're going to take a cold laryngeal mirror or dental mirror, put it under their nose, and if they have any type of nasal emission that shouldn't be there, that mirror will fog up. For prosodic evaluation, you're going to be looking at a lot of different things. You can look at it during any other portion of your evaluation. But you would look for things like the rate of speech. Are they, speaking a mile a minute when they shouldn't be, or are they going really painfully slow? Those types of things are going to tell you, is there an issue at hand? You want to look at bisyllabic words with a single stressed syllable. So things like baseball that I talked about earlier. If they say baseball like it should be, great. If they're saying baseball, they don't have any different stress there. Or if it's baseball, they're having a difficulty, kind of modulating where the stress should be. So that's an assessment task where you have a very confined issue of the stress belongs on this syllable. Can the person produce it the way that it's supposed to, or is that a challenge for them? You're going to want to take a look at their average vocal loudness and vocal pitch. And then you're going to want to just identify if they have any other aberrant productions. So things like inappropriate features, masked faces, rushes of speech, telescoping that we've talked about. And if you see any of things like that, that all falls under prosody. As far as apraxia goes, I did put some standardized measures for apraxia because they tend to be, subjectively on my end, they tend to be a little bit better and more standardized for apraxia. There are a couple of different standardized dysarthria tests, but they tend to be not super functional to administer in a clinical setting. So one you might come across, it's called the Assessment for Intelligibility of Dysarthric Speakers, or the AIDS. With that one, before we get into apraxia, you are giving the patient something specific to say, and you have to test their speech as far as their intelligibility, and then you have to give someone who's unfamiliar with them their intelligibility, and then you come up with a difference in intelligibility score. Intelligibility, like we talked about, is so subjective, so we have a standardized measure that's using a subjective measure to give you a score on something. It's just it's not really feasible. It also takes a lot of time to do, and you tend to not have that much time realistically in a clinical setting. So, kind of focusing on the other areas that I spoke about for dysarthria tends to be the better avenue to go through. But for apraxia, there are scales and rating scales for people with these issues, just because, like I said, the features that we're looking at are not so widespread like they are in dysarthria. So I'm not going to go through what each of these entails, because that's not something that you would be tested on the praxis. It's just good to be aware of them. So for your acquired apraxia of speech, you might have the apraxia battery for adults, or the ABA2, the apraxia of speech rating scale, or the ASRS. And then for CAS, there's a couple different ones. So you might have the dynamic evaluation of motor speech skills, or the DEMS, the Kaufman speech praxis test for children, KSPT, the screening test for developmental apraxia of speech, or the STDAS2, and then the verbal motor production assessment for children, or the VIMPAC, and then lastly, the apraxia profile. Another thing that you could do, if you're having a hard time kind of figuring out, is this an apraxia or an aphasia, and you think it's just an apraxia without an aphasia, but you're not 100% sure, test their writing. The reason for that is, unless they have a limb apraxia, and assuming there's not, someone with just a verbal apraxia is going to be able to write fluently, and that won't be impacted unless there's another issue. So if they have an aphasia and they do have an expressive issue, their writing will be impacted as well. If it's just apraxia without any other issue, they should be able to write fluently. All right. The last section we're going to go over tonight is the treatment of MSDs. The major thing that guides treatment of motor speech disorders is motor learning principles, or how we, what we use to guide learning of a motor movement. I've broken it down into what the principles are and what each part of those principles mean. So we have something that looks at massed versus distributed practice. In massed practice, you're going to have less time between your trials. So this is where you might have someone who's learning to say words, and you're just, showing them flashcards, word after word after word after word after word after word, a lot of practice up front. Whereas distributed practice, you might have them do 10 and then take a break, and then come back and do 5 and then take a break, and do 20 and take a break. You're going to have more time between the trials too. So it could be, you have 10 words, and then let's do 1, 2, take a 30-second little blip, boom, boom, done, keep going. With massed practice, that leads to better acquisition of the skill, and then distributed practice leads to more generalization of the skill. With the next principle, that's blocked versus random practice. In blocked practice, treatment targets are blocked in groups. So you can think about that, like if I'm going to use, treatment group 1, it's all A. Treatment group B, or 2, B. If you're working on block treatment, you're just going to go A. Then you'll move on to B. In random practice, you're going to start intermixing those groups. So it might look like AB, A, B, A, B. Block practice leads to that acquisition piece, and then random practice leads to generalization. The next one is constant versus varied practice. In constant practice, the target is produced in the same context every time you say it. So that could be, you're working on P, the sound P, P. You're going to work on it only in single syllable words in the word initial position. And that's all they're going to get. So pit, pot, etc. In varied practice, your target's going to be varied throughout different things. So you might have single words, but you're working on P in beginning, middle, and end. Or you might have single and multi-syllable words that you're working on, but also emphasizing your target. Constant practice leads to better acquisition, where varied leads to the generalization. As far as feedback principles go, we're looking at knowledge of results, or KR, versus knowledge of performance, or KP. Result feedback, or result knowledge, excuse me, is giving the feedback targeting the degree of success in achieving a motor speech disorder. So with that, you might tell someone your S might need to be a little bit crisper, or a little bit more sibilant, for instance. Or in knowledge of performance, you're going to be looking at the quality of the motor behavior. So you need to round your lips a bit more for production of O. The knowledge of results leads to better acquisition, and then your knowledge of performance leads to better generation. And then we're looking at the amount of feedback that you're giving them as well. So excessive feedback, such as like after every production, that might be less effective. Varied feedback, where you're giving them feedback after every couple of productions, or you do one and then take a break for a couple and then another feedback, etc. That can be more effective in helping with acquisition and retention. And then delaying feedback may actually improve motor learning. So instead of them saying, "Pit, you did a good job. That's exactly what we want you to say," they might say "Pit," and you might wait 2 seconds before you say, you needed to be a bit more plosive in your P. That way they can actually use that feedback to help modulate their motor production appropriately, and in what the way you're looking to help them do. As far as the treatment of respiration goes, I wanted to give a word on non-speech treatment tasks. I may talk about them a little bit later, but non-speech treatment tasks should really only be used sparingly and to model something as an underlying principle, because you really want to be functional in the treatment of motor speech disorders, no matter what subsystem you're working on. And doing non-speech tasks doesn't really do anything for speech. There's a lot of good research and bodies of good research on that. So getting off my soapbox here, an example of that might be if you really want to work on abdominal or diaphragmatic breathing to help them with their breath support, and they just can't get what you're talking about as far as, breathe into your belly. You might have them lay down, put a tissue box or a book or something along those lines on their stomach, and you're going to tell them breathe in so that that tissue box or book rises. And that's going to be a good visual cue for them that, oh, I got the tissue box to get up. That's what my therapist is talking about. And then you're going to immediately, once they get that, you're going to immediately pair that to, now do that without the tissue box and say your name, say have them do some kind of speech. So that they're getting used to doing that and pairing it with whatever production level you're working on. Like we spoke about earlier, their posture might affect their breathing. So if you have someone who's so slouched over that they can't get their good, chest expansion or good abdominal movement, they're going to have shorter speech. I just did that, and I had shorter speech because I didn't have enough room to expand anything to take deeper breaths. So you might work on them, physically putting them up and saying, "I want you to keep yourself here." If they have that type of control, awesome. If they don't, you might look at prosthetic treatments. So a respiratory paddle, something that you can hold up here, or abdominal trussing. You're literally going to like tie them to a chair, to help keep them up. If that's something that works, that's something that they might consider implementing in their daily lives to keep themselves in a better posture so they can have better respiratory support. Like I said earlier, respiration and phonation are really tied together. So you're going to want to work on them together to some degree. If there's someone who is, speaking and they only take those short breaths before they go, so that they only have short phrase lengths, you can bring things like that to their attention and say, you're not really taking a deep breath. I want to work on that so that you're getting more air in before you start speaking. That way you're able to say more and get your message across more effectively. More conscious identification of these types of issues can help your patients. And then again, biofeedback, like we kind of just spoke about with the tissue box book example, that can help them sense better breathing patterns, but you want to tie it to the speech tasks, pretty much as quickly as you can. As far as treatment of the phonatory system, you're really going to be breaking it down into whether they are hypo or hyperadducted. So hypoadduction means that they don't have enough vocal fold adduction or adduction. It means their vocal folds don't really meet in the middle, versus hyperadduction. They have excessive, so they're the ones that I was talking about earlier, where the vocal folds kind of slam shut. If we're looking at treatment of hypophonia, in the past, you might have been told or heard from people that they use something called an effort flow closure. That's, where you have the person grab onto the bottom of their chair and pull themselves down, push against a wall, anything like that, to really kind of force their vocal cords together to get them to voice a little bit more. That's not recommended, because if you do that, that can actually lead to another type of voice disorder. So they might develop like a compensatory muscle tension dysphonia, or if you have them pressing hard enough and speaking hard enough, they might end up like a vocal nodule or something like that. We don't want to cause issues for our patients when we're trying to treat issues that they already have. So I would steer clear of things like that. You can use things like LSVT, or Lee Silverman voice treatment. That is a research-backed treatment method that's been around, I believe, since the 1980s. That is specifically designed for hypophonia caused by hypokinetic dysarthria, but they have a lot of good research on other types of issues as well. And if you're interested, I encourage you to look through that body of evidence. And then you can also have digital manipulation. So if you have someone who has a paralyzed right vocal fold that's a bit more hypoadducted, you can, work on pressing on the left side, or excuse me, the right side of their laryngeal cartilage to try and push that vocal fold more into midline, to get a little bit better voicing support. On the opposite side, we have the treatment of hyperphonia. We're going to want to work on relaxation techniques. So things that will allow their vocal folds to relax a little bit and get a little bit better, more relaxed and easier phonation. They also can have biofeedback. There are biofeedback approaches that you can use, that show the person how much tension they have in their muscles and to work on reducing that tension. And then again, head positioning. So they are so tense down, stuck in more like what's called the chin tuck posture. You can try and work on that. You can help them try and stretch up into a better position, or they might have an alternate position that might be a little bit better. So again, if they have that, really tightly strung vocal fold, they might have to move to the side, to see if they can get a little bit better phonation with a head position change. As far as treatment of resonation goes, this is an interesting area because we as SLPs are not involved in the direct treatment of the resonation system. That means we don't treat resonance as itself. And I'm going to get into what that means here in a second, but we are involved in the referral process for these issues. So if you have someone who, their velum is just so flaccid or so spastic that it can't get up to close off their nasal cavity, like we spoke about earlier, you might want to refer them to a surgeon who can work on that. They might do something called the pharyngeal flap surgery, where they're literally tying that velum up, and kind of blocking things off. Or they might get a velopharyngeal injection, either, to the velum itself to plump it up, or to the posterior pharyngeal wall to plump that up so they can get better closure, things like that, that the surgeon will look at and do tests for and then ultimately intervene on. You might also refer them to a prosthodontist who's going to make a prosthetic for them. That's something that's in that picture there, which is a palatal lift. It's a little device that actually lifts up the velum itself so that it doesn't have to work as hard to close off the nasal cavities. But we as SLPs, we're not going to work on making that. We can refer out. The patient might also need a nasal obturator, so something that, sits on their nose like that and prevents them from being hypernasal. The downside is they start to sound a little hyponasal. What we as SLPs can do is we would work on any maladaptive speech behaviors that were caused by the resonance issue. So if someone is really, really hypernasal and they are straining to try and get their velum up, they might end up with, vocal issues. They might have, just kind of learned to speak that way. So we're going to work on, working on, in this example that I just gave, releasing their vocal fold tension, or, allowing them to speak without these maladaptive behaviors that they've developed. And then as far as treatment of articulation goes, like I said earlier, speech tasks need to be functional. Oral motor exercises are unfortunately used clinically, but there is no good evidence to show that there is any meaningful improvement in speech production or what's the word I'm looking for? I can't think of the word off the top of my head, but some people will go to a speech therapist and they have a facial droop and they want exercises to improve that. There's no good research that shows that if you're going to do oral motor exercises, that does that. So oral motor exercises, if you're not familiar, are things like, smiling to the point that you're kind of straining. So like that, or, sticking your tongue out against a popsicle stick for resistance. There's some evidence for swallowing disorders, but not for motor speech. And I wanted to make that really clear, just because you're probably going to come across them at some point in your career. I'm hoping that, as our field evolves, that these will be, ferreted out of practice, but right now they're not. Some appropriate treatments include integral stimulation, phonetic placement, phonetic derivation, compensatory maneuvers, and intelligibility drills. These typically end up being things like tongue twisters, where you have to be really good about speaking to get the point across, and they are challenging. Minimal contrast pairs and exaggerated speech production. I said that in an exaggerated way so that I was a bit more intelligible. As far as treatment of prosody goes, the tasks are usually geared at improving the naturalness of speech production. So if we're looking at treatment of stress, we can have a referential task. Things like that are, and they're also kind of tied with the contrastive stress exercise to some degree. But a referential task, you might have the same sentence repeated 5 times, but the stress is changing depending on how you want to get your point across. So if I had the sentence, Mark went to the store, and I said, Mark went to the store, I am stressing Mark there. That might be in response to who went to the store. And then, you could change it to, Mark went to the store. I'm changing the stress because that could be, where did Mark go? Same sentence, just different stress to really get your point across. Whereas the contrastive stress that can be involved in that, but on its own, you're looking at words that are spelled the same, but their stress is different. I'm trying to think of a good example of that, but I can't think of anything off the top of my head. Let me pull up an example here. Sorry, it's a little late over here where I am right now. Let's see. Well, I'm having a hard time coming up with a couple here. But like I said, they're words that are spelled the exact same, but with their different stress patterns mean entirely different things. Moving on, treatment of stress, you might also modify appropriate breath groups. So if you have someone who has really short breath groups, but if you think you can intervene and work on different things to get them to a little bit more appropriate one, let's say they have a 2-word breath group and you think that you can get them up to about 4 or 5 words. As their optimal where they have to take another breath, you could work on that. And then you can also work on modifying the timing of their breath so that their timing seems a bit more natural. And then as far as rate goes, you can have a pacing board like is pictured there, or a metronome. The point of that is to keep that person on time so that they're not speaking too slow or too fast. You're going to have to work with your patient to kind of figure out what their most optimal rate is. But those are different methods that you can use. And then as far as treatment of apraxia goes, the treatment consists of at least single syllables because we are working on those transitions. But you can adjust obviously up or down based on the patient's capabilities or goals. If you have someone who has such a severe dysarthria that they can't really initiate anything, that's where you might work on a single phoneme, and you might work on just producing ah and having volitional control of that ah. But outside of that, if you have someone who can produce some speech, you're really going to work on something that they have to sequence so that they're working on that sequencing skill. You have, for apraxia, there are articulatory treatments that look at rate and rhythm, and then treatments that work on prosody. There are treatments that are specifically designed for kids with CAS. Again, I'm not going to get into details on what those are because that's not something you're going to be asked on the praxis, but something you could look into if you're interested. Those include the dynamic, temporal, and tactile cueing approach, the Nuffield Center Dyspraxia Program, and then the Rapid Syllable Transition Treatment, or REST. Some global considerations to take into account for anybody with any type of motor speech disorder is you might want to consider implementing some sort of AAC or alternative augmentative communication technique. That way you're improving the patient's ability to communicate. Anybody who's less than 100% intelligible could benefit from some sort of AAC. That way they can communicate in 100% of their respective communication areas that they need to. Additionally, any speaker that you as the clinician thinks could benefit from AAC, something to bring up. As SLPs, we really do want to intervene on that speech system, but we also really want to work on communication. And if you have someone who you think from day one working with you would really benefit from a picture board, letter board, sentence board, topic board, things like that, that can help them communicate while they're going through therapy with you, you can work on that as part of your plan of care, and that can also make a really big impact on that person. So just something to consider. All right. I didn't see any questions come through here, so I'm going to assume that there are none. But if anybody has anything, please just let me know. I did have some questions at the end, but I've already kept you guys late. Well, I think I run into one last. Oh, no, that is the end. Okay. There we go. All right. So I know that was a ton of information. I know I kept you guys for quite a bit longer than some of the other lectures you might have had, and I'm sorry for that. It's just motor speech disorders is, like I said, it's a big area in our field. There's a lot of information to cover. So I appreciate your time. Please feel free to reach out to me. I'll leave my information in the comments section here. Please feel free to reach out to me if you want my slides or if you need any help. Better understanding motor speech. I'm here to be a resource for you. And with that, best of luck with your praxis. I hope you guys all pass the first time. I know you will. And I will see you guys next week as I am hosting the lecture for our next speaker. I won't be giving the presentation, but I'll host them. So I will see everybody back next week. Have a good night.